ladies and gentlemen. It's lovely to see you all here. Thank you for joining us here in Berlin at the World Health Summit, and a very warm welcome to those of you who are joining us online. I'm Shuli Ghosh, and I'm excited to be hosting such a prestigious panel of speakers on behalf of the IFPMA to discuss an issue that is rapidly growing momentum, that is prevention as a key strategic priority for healthcare systems and economic growth. To put it into context, preventable health conditions are costing G20 economies over $1 trillion every year in lost productivity. That is the same as the amount of income that was lost from the global workforce during the first half of 2021 because of the COVID pandemic. And that is on top of all the challenges that many countries are currently facing, aging populations, slowing economies, a looming NCD crisis, and competing spending priorities. Yet preventive healthcare, from life course immunization to early detection, early diagnosis, early treatment, they can provide significant economic and social benefits. Productivity increases, people can work longer, societies become stronger, more resilient, and the burden on healthcare budgets dramatically reduces. So the question isn't whether prevention works. We know it works. The question is, do we have the political will to act on what we know? And that is what we will be exploring with our wonderful panel. How do we quantify the value of prevention in language that resonates with policymakers? How do we unlock the benefits and move from a reactive healthcare system to a proactive driver of growth? And we also welcome your views. So in a little while, I'll be asking for questions and comments from you. Maybe you have examples, or maybe you want to ask questions of our panelists. We will be delighted to take those a little later on. So first, let me introduce our panel. To my immediate right, Professor Lotte Steuten, Deputy Chief Executive of the Office of Health Economics. She leads a broad portfolio of decision analytic modelling and health economic policy research programmes. Professor Walter Ricciardi, Director of the School of Hygiene and Public Health at the Catholic University of the Sacred Heart in Rome, Chair of the Mission Board for Cancer at the European Commission, and Chair of the European Mission Board for Vaccination. Francesca Colombo, Head of the Health Division at the OECD. She leads the OECD's work, which provides internationally comparable data on health and health systems and analysis of health policies. Dr. Belinda Nimako, Director for Policy Planning, Monitoring and Evaluation at Ghana's Ministry of Health, with extensive experience in health systems strengthening at local, national and international levels. And David Reddy, Director General of the IFPMA, the former head of the Medicines for Malaria Venture, also a board member for Malaria No More UK, and CEPI, the Coalition for Epidemic Preparedness. Speakers, welcome today. It's great to have all of you here. Let's start with some facts. Lotte, one of the most important preventive strategies in health is, of course, vaccinations, yet they seem to be underused, under-resourced. OHE has done some really interesting research looking at the economic value of adult vaccination. What have you found?
Yeah, so thank you, Julie. Indeed, vaccination is one of the most powerful yet underused preventive strategies that we have today. It helps, protect against infectious diseases, but there's also an important link to non-communicable diseases that can be, prevented or sort of stopped, where we have an impact. But indeed, in addition to the value of vaccinations to individuals and their health, there's also a very broad impact on the society at large, including the economy. And I'm sort of just framing the issue to sort of set up a little bit like what research we did and why that is so important. So indeed, we studied the full socio-economic value of adult vaccination programs. We included initially 4 programs, which were against flu, pneumococcal disease, RSV, as well as shingles. And we studied those in 10 countries around the world, including middle as well as higher income countries, to have a very broad, diverse set of countries in which we will be studying the effects and the value of adult vaccination. Afterwards, we also added COVID-19 to the set, and we also broadened the set of countries. And what we found is that these diseases really, that these vaccines really help against, help to save lives, to alleviate human suffering, to have an impact on healthcare systems and on societies more broadly. And in fact, this was a very, very big study, but the answer is pretty straightforward, and that's why I simply printed it on a t-shirt so that everyone can sort of remember that. So there we go. Take your photos to your cameras.
So that's $1 spent gets $19
Absolutely.
return on adult immunization.
Yeah, so the research we did, we studied, so this is not just a slogan, for the record. This is the headline finding of a very comprehensive study. We did a benefit cost analysis looking at the return on investment of the programs that I just mentioned across those countries, and indeed the return on investment is about $19, euros, pounds, doesn't matter, for every single $1 invested. And that's a very big number. Of course, like health economists, will always quibble a little bit about the methods and the details. So there's a very, very long report on the website that gives you all the details. But the fact of the matter is that we had to torture the data very, very hard with different methods to even get a number that was close to 1. So no matter whether we're sort of hung up on 19 or something close to that, it is overwhelmingly positive and a very robust finding. And that's why I printed it on a t-shirt.
We trust you. If you say it's 19, we trust you. So $1 spent on adult immunization can garner a return of $19. So that figure is astonishing. What do policymakers say when you confront them with this? Because very little money is actually spent on vaccinations.
Absolutely. So when I tell this to policymakers, basically they say, oh, Lotte, that sounds amazing. But, when can I see the 19 and which part is mine? So I can show you the 19 right away on my t-shirt. The t-shirt is mine, by the way. But that is the real sort of challenge here. Like, the benefits of vaccination are real, but they are very diffuse. They accrue to individuals, to the healthcare system, and to economies. And that makes it much harder to understand who should be taking the responsibility, the proactivity, the first step to put in that one that will help us unlock the 19, and that is the challenge. So what we did in this study also is to unbreak like which part of the 19 falls on which part of society, which part falls to healthcare system. So for example, we see that in the UK, about 1 million of bad days could be freed up every year if we prevent those respiratory infections that those vaccines can prevent against. That's a very tangible and short-term impact. And for employers, one more example is we see currently the cost of respiratory diseases are 44 billion to UK businesses each year. So they too stand to gain a lot from vaccination. And those are more tangible, actionable results, I think.
So those are some amazing figures. Lotte, thank you very much. Walter, one of the biggest challenges faced by policymakers is the fact that many countries' populations are rapidly getting older. What does that mean for economies and societies and healthcare systems?
But you don't need to be an economist or a demographer or an epidemiologist or a sociologist to understand this. I mean, this is the mean Italian family. Of course, I speak from the European Union point of view. In the 70s, you can see 2 children, 2 parents, 3 grandparents. This is the current mean Italian family in 2025. 1 child, 2 parents, 4 grandparents, 2 grandparents. I mean, of course, it's understandable. That is not sustainable. In particular, if people high on the pyramid are sick, as it's happening, because essentially what happens is that in Europe we have a quite low life expectancy, but the health span of the life expectancy is decreasing rather than increasing because of different reasons. This means that in Europe, in the European Union, we have less than 5% of the world population, and we spend more than 50% of the money spent globally for welfare. This, of course, is unsustainable, particularly if we are in trouble with wars, with economic recession, with climate change, with biodiversity collapse. So we face so many crises altogether, we have to act. This is not sustainable.
And this is a crisis which is on our doorstep now. Healthcare systems in many countries are becoming unsustainable. How do we build in sustainability through preventive strategies like immunization? And how should that be a part of fiscal policies?
There is a new approach that we are now following, which is working, of course, with economists, but working also on the people that advise the Minister of Finances at European level. We produced a paper recently together with Professor Bordignon from the Catholic University in Milan, confirming what Lotte say about the investment, the return on investment on immunization. But we also looked at change of lifestyles in order to prevent chronic disease and improving cancer screening. And that is a massive amount of prevention that we can do, really making our system sustainable. So without that, our systems are not going to be sustainable. How do we convince policymakers who are in charge? I've been advising several prime ministers, in particular Professor Monti and Professor Draghi, who are renowned prime ministers. When they were in charge, when they were on duty, of course, they didn't listen to this advice. Of course, now they are not in charge anymore, and they're pushing this. The problem is, how do we convince Prime Minister and Minister of Finance who are in charge to take the most appropriate decision?
Well, that's the million-dollar question.
And this is essentially a matter of fiscal sustainability. So our proposal is, again, together with the expenditure for defense in Europe, again, from a European Union perspective, bring this chapter of prevention outside of the Financial Stability Fund, which means that countries can spend freely in prevention, in cancer screening, in improving and modifying lifestyles and immunization without the concern that this is going to be affecting their public debt.
Right.
Okay. This is a practical, and I can tell you that we are receiving a lot of good reactions from some member states, because in European Union, the responsibility for healthcare is in the hands of member states. So I'm confident that this is going to be a practical contribution to make it possible.
Oh, yeah, and we'll talk a little bit more about that. Francesca, your work revolves around analysing health policies and advising policymakers on what gives best value for money. What are you seeing in terms of health spending trends, health of workforces? What are your major concerns?
I'm quite glad you bring in the workforces and the health of the workforces, and I'll respond. You mentioned two things. One is on financing trends and obviously fiscal sustainability, and we heard from Walter, and that's, the trend is quite clear. The health system will continue to absorb more resources simply because, populations are getting age, because there is a burden of disease and so forth, and because also the way health systems are set up, they tend to be more, find it difficult to have productivity improvements and so forth. But I think the health of the workforce is a very important one. I mean, if you look at the demographics, we always focus on the 65 plus. And that's obviously getting a bigger part of the populations. But actually, the workforce itself is aging. And so, between now and 2060, you're going to have about 30% of the health workforce that will be between 50 and 64. And I think there is a very powerful productivity and economic imperative for employers themselves in keeping that workforce healthy. And at the moment, we are not really able to do that. So we know that we're living longer, but the extra years of life are not necessarily lived in good health. We know that individuals who are, if you want, the older workers, so between 50 and 64, if they have two chronic conditions, only about 40% of them are employed. If they have one chronic condition, it's about 60% are employed. The more you add then a chronic condition, the less participation in the labor market you have. And I think from a productivity and growth perspective, making sure that we have this health of the workforce, it's a particularly important one. So I think there is a role for employers here to play. I mean, we talk a lot about finance ministers and their role and so forth. I think we need also to bear in mind the role of employers and of the labor market, which is perhaps sometimes not spoken as much.
And the reality is, and I don't want to depress anyone in the room, but as the years go on, we are going to be working longer. We're going to be working, beyond 64. That is just the way the world is going. How do we get? You talked about bringing in employers. Also, governments have to be involved beyond the health sphere, don't they? We need to bring in government departments from across all the sectors so that they can align their strategies. How is the OECD working on that?
Look, in many ways, and I wouldn't say that it's not easy. During the pandemic, everybody from across the house in OECD was coming to us. And now, we're us knocking at the door. No, I'm joking. We work a lot cross-sectorial. But I think when ourselves in the health sector want to be heard as well, whether it's from Ministry of Finance or other sectors, we need to speak more their language. And what we're trying to do in our work is to demonstrate the returns on investment, not just in a broad sense, saying if you invest X in prevention, that's what you get in returns, but saying what are the co-benefits? What are the co-benefits for the labor markets in terms of productivity enhancement, in terms of reduction in exit from labor markets, so increase in participation? What are those co-benefits? And that's measured in terms of jobs, in terms of productivity. It's not measured in terms of quality and dailies, which is what we tend to do. Or when we go and talk to finance ministers and our models show, okay, if you invest in prevention, those would be the benefits in terms of GDP and growth. So in a way, it's like saying, okay, those are the benefits of prevention, but let's then use a metric and a language that speaks in terms of the co-benefits for other sectors. And we're developing also what would be the impact of prevention on labor, on human capital formations, because that speaks to education ministries as well. So I think that co-benefits perspective, it's something that we need to, even in terms of communication, but also in terms of numbers, that we need very much to work on.
Well, this is a great place to bring you in, Belinda, with your experience of Ministry of Health. We know that prevention remains underfunded in health systems worldwide. Why is that the case? What's been your experience in Ghana?
Thank you. So I think it's one of many things. One, prevention was initially seen as a nice to do. So rather than a must do. If you are in a fiscal constraints or like low resource settings, your priority is when people are in hospital, you want to treat them. It's more fanciful. It's something people see. So it doesn't usually come intuitively, the value of, let's say, immunization, the value of making sure family planning commodities are available. And you'd realize that that's really where the work is. So I would say, one, that initially it was a nice to do. Secondly, also, at the end of the day, the people who call the shots are the politicians. You would say it's the policymakers, but the policymakers report to the higher-ups, who are the politicians. And for the politicians, it boils down to money. To votes. So I worked in the district once as the district medical officer. I needed funds for something that was health screening. My member of parliament wanted to put hospital beds because that's where the photo op is. That is what people would see rather than something abstract. And until we are able to provide the evidence base, like Lotte just did, telling us the returns on that investment in prevention, we are not able to break through.
But as you mentioned, that figure from Lotte is incredible. $1 unlocking $19. But the trick is getting policymakers to unlock that first dollar. How do you do that?
So I'll tell you how we're trying to do that in Ghana. You would realize that, yes, all these cost-benefit analysis have been done. The investment cases have been done at the global level. When you're working at the country level, as I do, you need to break this down to concrete numbers for the policymakers, for the purse holders, i.e. our counterparts in the Ministry of Finance, and even for the politician. One way we've tried to do that is looking at the whole health prevention and promotive benefit package and costing it. So we've looked at a bundle of services along the life course that if we deliver as a bundle, we can meet the essential needs of our people. And we've costed that to be a minimum range of about $5 per head, per person at the population level, to a maximum of about $9 per head. Armed with this work that we did with our partners, we went back to the politicians and to the Ministry of Finance to say, if you invest this amount, we'll be able to deliver these health prevention and health promotion services. But guess what? They asked us, how does that translate to hospitals? Hospitalizations you would have it. What does that mean in terms of saving for me? And beyond giving them that concrete number, which got them to listen to us, The other thing we did was to contextualize this evidence, which is very important in prevention. So in our costing of that benefit package, we are looking at services being delivered in places like marketplaces, schools, religious settings, because that's how we would do it. And so being able to, one, provide that concrete number, being able to contextualize the evidence, have given us the year of the politician, but they also want the next thing, which is, what does this mean in terms of my limited resources managing? But I'll be the first to tell you that this is the science of it, but there's also the art of it, which is the place of activism. In Ghana, health is politics. You would find health on the party manifestos. You would find health on the front page of the newspapers. And that hasn't happened in vacuum. It's because over the time, we've built a health system that people trust, that there's demand for. And that has translated to prevention. So when we run out of vaccines, we were talking behind the scenes, policymakers, nobody was minding us. But when it made it to the front pages of our national newspaper, within 24 hours, vaccines were sought from another country.
So public pressure for vaccinations is key in this.
It is key, activism. And that activism, you will talk about the media, but the media makes sense because people care. So what it means is those of us in the policy spaces, those of us in the science, whether researchers, etc., we need to realize that this whole making prevention an agenda for the purse holders, for the politicians, boils down to how much we empower the people, how much we educate them on the benefits of prevention and health promotion, for them to demand that of the politician. That is the only way we win it.
That's a really interesting point. So over and above all the data and the economic analysis and the savings and the return on investment, you need to get the public behind you as well. Thank you, Belinda. I'm sure we'll explore that in more detail a little later on as well. David, pharmaceutical advances are pretty much transforming the way we prevent and decelerate the progression of diseases. How can industry then help drive this momentum towards the mindset of preventive care as an investment?
Okay. Thanks very much. And I think what's really nice about the panel, we've gone across all of the different elements that are required really to ensure that we can make advances in healthcare. And one of them is innovation. And I think that is central to the role of industry, and that is driving innovation. We've got a strong focus on primary prevention through vaccination, but also through secondary prevention, so the prevention, early detection of disease and prevention of it going into more disabling, far higher morbidity, and eventually death. So if you can intervene early, you can get far better outcomes. And this is something that as an industry we're trying to drive, because that can actually drive some of the economic rationalization we're looking for. So central to this is the availability of new interventions or innovation. One of the challenges right now is that a lot of the intervention is just seen as being commodities, but actually there is a true value system and a true investment behind this. If you look at the level of investment that's required, in 2022, the innovative pharmaceutical industry invested around $167 billion during that year in trying to drive the R&D that will bring forward the next generation of medicines. That process is moving faster. Over the last 20 years, there have been 942 novel active substances introduced, and some of these are having real impact today. If you look at it, I think, just to focus on a few areas, if you look at HIV, now, one of them is the vaginal ring, which gives women new choices. Now, that actually came out of a product development partnership, which is something that I'm very familiar with as well, but this is with industry working with not-for-profit organizations.
And this helps prevent HIV.
So this helps prevent HIV. And it gives women choices where ultimately, in some cases, their partners wouldn't wear condoms, etc. And so it puts choice back into the hands of women, which is empowering. And it's also has a huge health benefit side. And then you've got long-acting prophylaxis like lenacapavir, which is taken twice a year.
That's the injection twice a year
that
stops you getting HIV in the first place.
And it stops you getting HIV, and this can be incredibly effective. but also the potential for this in terms of curbing rates of HIV moving forward is really significant. I think one of the other advances that everyone is acutely aware of is in the non-communicable diseases area with the GLP-1 receptor agonists that have come forward and their role in diabetes, their role in obesity. But then if you look at the other diseases that are associated with this, we're beginning to see now reductions in those diseases as well. And that means that we also have to look at comorbidities a lot more seriously, because if we can get this type of early intervention, we can actually drive down a broader range of illnesses and prevent them from becoming more serious. But I think just to finish, that on a note of optimism, which I think today we actually need, there are 12,700 compounds in clinical development at the moment. That's an extraordinary amount. That's across industry, it's across academia, etc. And we have the rise of artificial intelligence as well, that has the potential to really help make our R&D efforts a lot more targeted, a lot more successful in future. So I think if we can sustain an environment that continues to nurture and reward innovation, there is a lot of reward that can be reaped out of this, and that can be turned back into interventions which are actually cost-saving for society.
Do you think one of the problems is that governments often see R&D and innovation and preventive medicines as being the remit of industries, when really they should be seeing preventive health as one of the strongest investments that a country can make? How do we change that mindset?
Yeah, it's clear they should be seen as an investment. And one of the things is that we need both a mind shift and a policy shift from treating illness as a cost to investing in health as a driver of economic growth. We know there are a lot of out-of-pocket expenses for patients in some countries, and reducing those is critically important. But just a couple of examples that might be helpful. Going into malaria endemic regions like Ethiopia, and also, I've visited Manaus as well in Brazil. What you see is the direct impact of something like malaria on families. Now, we know that there is a vaccination for children available, which is partially effective, and there's also intermittent preventive treatments, etc. But what you see, the recurring theme is that somebody in the family gets sick, and it's generally the mothers or the daughters that have to look after them. And so you're getting a curbing of the family's ability to earn, but you're getting a stunting of the educational development, particularly targeted at young women. And so this has a negative spiraling effect, both at the level of families, communities, and economic growth. And in the global north, we mentioned the demographic cliff as well. I see that every morning when I look in the mirror. We do have an aging population. And the only way around this is by trying to preserve health and moving from a concept of lifespan to health span, and so prevention and earlier intervention, screening and intervention.
David, thank you. Thanks for laying out the broader picture, speakers. Look, let's have a wider discussion. So let's have a look at perhaps some solutions and how we can tackle some of the challenges that you've spoken about. What kind of solutions then should we be looking at to tap into this prevention first? So one example I can give, in the UK, for example, there is a shift towards pharmacies offering more services and more vaccination services. It's a simple move, but it requires investment and proactive action. Is that kind of thing useful? What do you think about that, Lotte?
Yeah, that's absolutely very useful. First of all, making sure that healthcare is accessible, and pharmacies are very well set up to deliver vaccinations. So we've seen that as well in the UK as well as in other countries. And also we see, in addition to that being sort of more accessible for everyone potentially, because pharmacies are open much longer, you just go there, you don't have to wait like almost 2 weeks to get a GP appointment like in the UK. So in addition, what we also see, particularly in more rural areas, delivering vaccines through pharmacies can also help with equity issues, where people have more opportunities to go and get the vaccine, rather than having to take time off of work, for example, which is not obvious for everyone. Maybe if you're a white-collar worker like me, it's relatively easy. We get them in the office, by the way, so that's even easier. But that doesn't happen for everyone, and I think having that level of that element is important too. And I think one of the challenges we also see that when we look at the value of vaccination, we really focus often on the healthcare system value. So pharmacies would be a part of that. But by doing that, we basically are optimizing cost effectiveness for a healthcare system, whereas the cost effectiveness for society is much bigger if we also include productivity, broader economic elements. And I think that's another very important barrier where we should be looking at and change.
Yeah, I mean, you've all talked about the problem that politicians tend to have short-term vision. They don't like investing a huge amount of money up front, where the benefits are seen long after their electoral cycle. Does anyone have any practical solutions for dealing with that? Walter, you talk a lot to politicians.
Yeah, I've reached the conviction after chairing the Mission Board for Cancer 6 years and the Mission Board for Vaccination 3 years, that the only possibility to have a concrete solution to this very complex problem in this very polycrisis world is a mission-oriented approach. For those who are not familiar with the mission-oriented approach, it was inaugurated by John Fitzgerald Kennedy with the mission to the moon and was operationalized in Europe by Professor Mazzucato in the 1918 together with Pascal Lamy, former Director General of the World Trade Organization, which means bringing together, since the very beginning, politicians, managers coming from public and private organizations, professionals, doctors, nurses, according to the different fields, citizens and patients, which are two different categories, because when citizens are healthy, they want to pay the least amount of money for taxes. When they are sick, they want immediately the most expensive drugs, possibly close to home. Industry, the sooner the better. Media. So working together since the very beginning and having a substantial funding from the public administration, as we've had for the 5 missions. What are the 5 missions in Europe? Climate change, water, food and agriculture, smart and neutral cities, and cancer. We have had 10 billion euro for that, and we have spent a lot of money successfully in 6 years, bringing together, in particularly, the engagement of citizens. So we shaped the solution according to the citizens. We spoke with citizens. We involved citizens very much. I think this is the only practical way to solve complex problems. If politicians work in their silos, if managers work in their silos, if the health people work in their arena and don't speak with other kind of, we are lost. This complex world is too complex to find complex solutions.
Perhaps a more general point, because of course we can make arguments, including in terms of return on investments and the benefits for economies of prevention and public health, and that's what we do. But I think we need to address also the broader picture, including of health spending. Unless we tackle low-value care or ineffective spending elsewhere into the system, in a context of quite tight fiscal budgets, it's going to be incredibly difficult. So you need to have also this broader picture as well of, to one hand, trying to really to reorient the system to be more prevention-based, which means also dealing with all the rest of the system. And I'm not saying that we don't need to have a curative system. We do. We want to have a curative system which is very efficient, which delivers the best quality of health care, but we want also to get rid of the ineffective care, of the low-value care, and all of those issues which are pervasive, unfortunately, in the health system. We need to address it. On the other issues going on to, how to convince also, some of the Ministry of Finance or whatever, there is perhaps more the health system needs to do in terms of engaging with finance on improvement of budgeting practices. So there are some innovations which are coming out in some countries in terms of having frameworks which go beyond the immediate fiscal year, so multi-year, health spending frameworks. They exist in a handful of countries. Actually, all the countries always, when they go in discussion with Minister of Finance, have an idea what are the expected health spending next year, but also in the coming years. But then those, if you want, estimates of spending over the medium terms are not taken into consideration in building then budget frameworks. And I think that's much needed. or things like performance budgeting, so including elements like those returns on investments or elements of performance that are expected from spending directly into the budget practices themselves, or ring fencing, which is not liked actually by Minister of Finance. But so there are budgeting practices that can be put in place to facilitate that more longer term look in where do we want the money really to be going.
It's a critical issue, funding at the moment, particularly for low and middle income countries, because we've seen a substantial drop in global in development aid. Belinda, how have you responded to this in Ghana, and what kind of financing mechanisms are you now having to look at to sort of try and close that gap?
So you're right. Our funds have dwindled quite significantly, like many other countries, and I think it's a worldwide phenomenon. When that happened, I mean, the most significant of all, which was the USAID, because that was a bit more dramatic, it was a bit more sudden as compared to the UN agencies that's evolved over time. We had a presidential directive, which was for the national health insurance to fund that gap. Following that directive, that's where the real challenge, emerged, because what are these gaps? How much is it? Because some of the funding does go directly, it goes directly to maybe implementing partners or points of service delivery, which at the national level you may not necessarily have overview on. Some of it is also for program management, but that's not necessarily what the government wants to plug, the gap the government wants to plug. And that's where the challenge emerged, that how do we convince Ministry of Finance that these XYZ are the gaps and I need you to put the money in. It was helpful to have the presidential directive because it became a stepping stone to triggering that funding from the Ministry of Finance. So that's one. The second is what I mentioned earlier, that in Ghana, health is politics. So prior to the most recent election we had last year, there was a big issue on the agenda, which was that whoever wins power needed to uncap what we call the National Health Insurance Levy. It's tax that is taken from the people, but there was a capping on how much of it goes into health, and the remaining goes into a consolidated fund, which is not necessarily for health. But people said, you are taxing us for health, it must go into health. So the other thing that has happened is now that tax amount has been uncapped. What that did was it released about a third of the additional value of the revenue that's generated from the tax. So all of a sudden, we have over $300 million as a result of that uncapping. And part of it was to go to plug the gap. So in terms of how we've responded, it's really been driven by the politics of the space and how we've been able to convince the Ministry of Finance on the specific needs that money needs to be released into. But having said that, I think the other bit of it is also just being able to build coalition. And being able to build coalition always is helpful in this context, whether with our CSOs or with multilateral. So when I don't have funding for vaccine, I whisper to UNICEF, could you please make it an issue? When Gavi comes in country on a mission, we don't limit the visit to the Ministry of Health. I say you need to cross over to my Ministry of Finance and tell them that I have this funding gap and help me raise the money. So ability to build that coalition across sectors with the relevant people have all been helpful. What about coalitions with the private sector
as well? Coalitions with the private sector, partnerships with the
Absolutely, absolutely. So being able to do that tax-free does help. And also, finally, I think what has been helpful is being able to talk in terms of the politics of the space. I keep going back because I've seen that at sub-national level and I've seen that at national level. Being able to tell the politician, you need to invest in this, and that cuts across, not necessarily just to prevention, to say you get so many votes from this area, so it's not helpful to cut them out of investments. You need to put a hospital there. That is how you get their attention. Being able to tell them, did you see the furore that happened when we ran out of vaccines? Yeah. That's what gets them. And now in Ghana, we're doing something we call the Ghana Medical Trust Fund, which is for NCD, specialist level care, and something that's also called free primary health care, which is to grant universal access to primary health care with a heavy dose of prevention and promotion. And the reason why these are national priorities now is because they were driven by the demand from the people. So I keep going back to that whether it's short-term view, medium-term view, long-term view, at the end of the day, people want to look good. And when they want to look good, it's what the people want from them. And similarly, it's also about regional efforts. Our governments, our ministries of finance, they want to look good, across the sub-region. So when you go and you say, okay, countries in the sub-region have introduced sin tax, it's relatively more easy to have the idea to introduce that tax on the sugary beverages, the tobacco, and the alcohol. And now we've gone back with another act that, you know what, we went to hunger, and most people are applying that tax to health. Yeah. Especially also for health prevention.
Well, that's a great, that's one of the mechanisms that the UN advocates, sin taxes and taxation on products that can cause long-term chronic disease. So that, at its very basic level, is a preventive medicine strategy. David, do you want to touch on what Belinda said about the industries as part of partnerships and coalitions? Are you finding that there is more pressure on industry to sort of step up because of the increasing financial pressures, the drop in development aid, etc., particularly in developing countries?
So just a couple of thoughts on that. So I think industry has been leaning in on many of these topics for a good period of time. I think one of the challenges is that groups often try and prescribe what industry should do as opposed to asking them what they can do. And I think there's an opportunity to partner a lot more strongly with industry as thought partners in the discussion as well. But I can give a concrete example of just one initiative that I've sort of learned about in the last couple of days in preparing for this meeting, which I thought was just stunning. And it really gets to your point about, politicians need to see things that look good. And there are really, really good examples of partnerships and progress out there. Is there anyone from Egypt in the room? Okay. So this is a country that I think should feel really proud and rightly proud of some of the work that's been done. There was a presidential initiative for women's health in 2020 that started up. As part of that, they're looking at breast cancer screening. 33 million women have been screened, and the rate of early diagnosis has gone from 30% to 80%. And the rate of late-stage diagnosis has dropped from 70% to 20%. That's just flipped. That is an amazing achievement. The average time from diagnosis to treatment has gone from 120 days to 49 days.
Wow.
And it's saved $127 million. Now, this has been done in partnership between industry, but with strong commitment and leadership from the Egyptian government. And this is the type of example we need to be showing, because really, this is the way forward. I think that industry definitely has a role to play with the Accelerating Access Initiative that industry forged. It's working very closely with the World Bank, and this is centered on financing. And they've now set up hubs, financing hubs, where they're really looking at, for each different geography, mixing of domestic funding, of international funding, of innovative funding, and of private sector funding. And we need to leverage absolutely everything here, but it's through partnerships that we can actually make the most progress. And just, I think one other comment is I don't think there's a silver bullet here. I think moving to prevention, diagnosis and early treatment is a great lever, but there's also getting the inefficiencies out of the system. So how can we use digital technology and AI to do that moving forward? But also, you know, one thing that is heartbreaking is when families and individuals spend money to try and cure ill ones, and they're buying falsified and substandard medicines. And this is still an issue in far too many geographies that is just sapping the life and the resources out of healthcare systems. So I think it is a multi-pronged approach. We need to be leaning in, and industry is involved in each of these areas. But it's complex, but we can make progress. And I think the example from Egypt is a shining example that we can look to.
Thank you, David. I want to pick up a little bit and have all of us talk about something that Belinda said, which is really interesting to me, that you can push politicians into making shorter-term decisions by the weight of public opinion. And I wondered whether, do you think the public has enough awareness of the benefits of prevention and immunisation? I mean, most parents, I think, would think vaccinations are for children, right? And we don't really think, I mean, I certainly don't tend to think of adult vaccination unless it's the yearly flu jab, which I get at my local pharmacy every year. But I wonder if we should also be raising awareness among the general public. Is health literacy an issue? Francesca?
Oh, it's a huge issue, and I mean, you're completely right, the weight of the public. But you also mentioned prevention. It's true that when you look at the weight of the public, very often it's more about, you know, the services that I deliver and making sure that that's available and quality and so forth, and perhaps much less on the prevention side. Now, we have a survey at OECD which on a risk that matters surveys, and health comes always as 2 or 3, now security has taken a higher, you know, ranking in terms of the risk that matters. So health is something that individuals do really think it's very, very important. But it's true that in terms of mobilizing the public around health, very often it's around, do I have the hospital just down the streets? Do I have the doctor? Of course, GPs, I mean, shortage of GPs, huge issues everywhere. But it focuses very much on those aspects of the delivery system. Very important, fundamental, don't get me wrong. Perhaps less on the health literacy for making sure that you have a healthy life through prevention, through life course, lifestyles, and so forth. So I think there is an issue here, yeah.
What do you think?
I couldn't agree more. I mean, just to give you an example, in the Mission Board for Cancer, we gave 2 billion euros to research, prevention, diagnosis and treatment, and quality of life. All the money for research was invested and spent. All the money for diagnosis and treatment was invested and spent. All the money for quality of life was invested and spent. The money for prevention is lagging behind. Why is that? Because government don't feel the responsibility to invest in prevention. So how do we act? We try to act in Europe, asking the European Parliament to provide a kind of moral mandate for governments to invest in prevention. So it's not mandatory from the legal point of view because healthcare is in the responsibility of member states. But at least in Europe, at the moment, there are countries which have no public cancer screening program. You know what I mean? So essentially, this means that people are not going to strike for this or to rally. So it must be the government. And of course, this is for cancer screening. We have to do that for immunization. We have to do that for the quality of life, lifestyles, and commercial determinants of health. I think that there must be a push from the elite, can we say that, coming from the political world, the managerial world, the industrial world, the professional and scientific world, to push in this direction. Otherwise, things are not going to be real.
Walter, I know that you were involved in a recent report which involved Vaccines Europe and the IFPMA, making the case for embedding preventive healthcare into EU fiscal policies. What has been the result of that? How has that been received?
There are countries which are very interested. I mean, I work in Italy and France. I can tell you that the Italian Under Secretary for Finance has said that even more active than the Minister of Health, I must say. So, because he's now understanding that there is a substantial possibility for the Italian government to make the NHS sustainable. If there are 2, 3, 4 member states that start to experiencing that, can go in the right direction. On the other side, there is a negotiation which has been successful for the expenditure for defense and the military at the moment. We hope that keeping that focus and the momentum also on prevention in this direction can be successful.
Lotte, do you think that, things like that report, does that add momentum to unlocking the potential of adult immunizations?
Yes, absolutely. And I think we see across many research reports that indeed the value of prevention, adult immunization being a big part of that, really falls back, as I said before, to the healthcare system, but often multiple times of that same value outside of that. So we have to think broader fiscal policy. It's like a rising tide lifts all the boats, right? If you have more productivity, if you can manage to find more fiscal space to invest, then you can also pay more for your healthcare system. And I think that brings me to one very important point. Prevention pays off in the long term, but not necessarily only in the long term. And again, adult vaccination is an example where we see the payoffs in the same year. So the short-termism that sort of basically is quite often seen as a barrier for prevention, because many prevention efforts indeed pay off in the long term. It's not always the case, and I think we have to be much better as researchers and as people to make politicians, policymakers aware of that, like what are the short-term impacts and also how does this accrue and increase over time. As Francesca said, multi-year budgeting is very important, because if you think again about vaccination programs, you need the infrastructure. And if you have the infrastructure, you can do these things for many years. So it is really something that you would have to build, but it's not necessarily something that only pays off in the long term. And I think we have to be very mindful of that.
Thank you. Belinda, do you want to say something?
Yeah, I wanted to add that within prevention is the issue of prioritization. That is something that we've grappled with, and I'm interested in hearing feedback on this, but anytime we've tried to push the prevention agenda, not to say in isolation of treatments, but also just to make a case for prevention, we've always faced the question of what do we prioritize? That is where putting the numbers on whether the burden of what you want to avert comes in handy, or the cost of that prevention strategy that you want to roll out. But it's always been that you have all this, a suite or a cocktail of interventions you want for a particular demographic, but within this, what do I prioritize? So whether it's adults vaccination, whether it's the national vaccination program, what goes into it, it always boils down to the issue of, what do you want us to prioritize, or what do we get the most returns from within this bucket? And whenever we are unable to respond to that well, we are found wanting. So personally, anytime we try to talk about the issue of prevention, my question that I've always sought to answer is what should drive our priorities? And when we figure that out as to what do we prioritize within this whole bucket and what are the reasons driving that decision, it's a little bit more easier to sell, whether to the finance ministry or to the government, but that's where the work is.
But when you're looking at what should take priority, I mean, policymakers have data available from the OECD or from, bodies like Walter's work. How the data is there and the evidence is there. Why is it not being acted on? They don't need to guess. They've got the answers.
Well said. When you have limited resources, regardless of the data, you can't do it all. And when you can't do it all, I know that I need screening programs for cervical cancer. I need for breast cancer, for the women, I need for prostate cancer, I need to do my GI, cold blood, etc. But when you cannot introduce it all, who do you introduce it for? What do you start off with? These are real everyday questions that politicians in low-income settings like me need to grapple with. And so that is where it becomes relevant to have that context-specific evidence, or to translate some of these, research or to, cascade it down to even the national level to help in that decision making. Because like currently we do want to roll out a national screening program, and this is what we are working with partners to decide on. So yes, the evidence base is there, but that evidence base needs to be localized and it needs to inform the prioritization.
That's interesting. So, I mean, this must be incredibly frustrating for all of you speakers who all have your own wealth of bank of information and evidence and data that it's there, but it has to be applied to certain contexts before anyone will listen. That's clearly one of the problems that you're coming up against, right? Go ahead.
You mentioned context.
Yeah.
Yeah.
Well,
I mean, I think we go back to the issues. Yes, the data, the evidence is there, then the decision making, the prioritization process. But I think I would say also that when you talk about prevention, we need to look not just at what can be done within the health sector, narrowly defined.
Yeah.
I mean, there are a lot of interventions which are actually taking place outside of the health sector. So there is this, more cooperation, collaboration, whole of government perspective. It's actually not easy sometimes to get, just because other ministries as well have different objectives also that they want to achieve, and sometimes it's not easy to recognize. And I think from the health perspective, it's not just going there saying, okay, this is good for the health of people, but also what is good for you, given your objective that you have as education ministers, as even agriculture ministers, which is always a very difficult one, and so forth. So I think we need to find those, mutually reinforcing benefits and arguments that will really drive the agenda beyond just the budgets of health ministries per se.
Anyone else want to say, Walter?
Yeah, we haven't discussed yet the elephant in the room, which is what's happening in the United States, where the Secretary of State is the fake news disseminator-in-chief, and 6 surgeon generals have publicly, having served both under Democratic and Republican Party, have said this is really making fake news and harming the health of the Americans. This is not happening only in the United States. We have to be very careful because there is the risk that is happening in other parts of the world, because the fight to science is not the fight only to scientists, university, academia. Is a fight to a correct way to take the proper decisions for the interest of population. So it's very good that in Europe, the President of the European Commission is going to propose a resolution to the European Parliament protecting academic freedom and evidence science. And science. It's very important that all over the world, scientists do not stay only in their labs, but really are aware that populistic party can really make the situation very worse, and we have to defend science and defend democracy.
Well, since you've brought up the American elephant in the room, what does anyone think of the UN political declaration on NCDs? Obviously, the US didn't endorse it, but there was a lot of general support for it. Do you think it went far enough on the issue of prevention? Does anyone have a view on how that political declaration at such a high level can move us along and propel momentum towards a more preventive strategy? Did it say enough about prevention? Talks about lifestyle changes, about taxing sin taxes, etc. Was it helpful to this agenda?
I don't know if I respond to.
No one wants to say anything. Okay, Belinda, why don't you start and then you, David?
So I believe so. If you look at the main commitments in the declaration, one of it was about multi-sectoral approach, and we've just heard how for prevention, really, a lot also happens outside the health sector, where even for the sin taxes, we're looking at food and trade industry. If you look at the commercial determinants, that's outside health. So far as one of the main commitments recognize the need for that multi-sectoral whole of society approach. I believe prevention is in there. It also, one of the commitments, if I remember, it's still early days trying to implement it, also included strengthening primary health care. And if you look at prevention, the main vehicle for doing that is primary healthcare systems. And so prevention will not necessarily happen in isolation. It's going to ride on that robust primary healthcare system. So in my opinion, these two commitments that the declaration called for primarily amongst the others did make a case for prevention in some form. And once countries are committed to that and start working towards that, it's a good platform to promote the whole prevention agenda.
David?
So I think there are a few good things in the political declaration. The first is, I think, the reference to vaccinations and its role in reducing NCDs. So, we see this with HPV vaccination, with hepatitis vaccination, but I think even if you look at influenza and COVID, etc., you're going to get far worse outcomes and severe illness in people with comorbidities. So underlying heart conditions, etc. So I think that was, it was very helpful to have that pointed out. I think the next thing was just it highlighted the importance of research, continued research and development in the private sector in that. And I think that endorsement, that recognition is really important. I think one of the things we really need to see, though, is that this does need to move from a political declaration to actually implementation.
Yeah.
And what that requires is it requires intentional plans, it requires financing, and it requires accountability. And I think that is the next and the most critical step. So moving beyond a declaration to impact is what we're looking for ultimately.
I'm going to take questions from the audience directly after this next one. So I just want to alert you that I would love to hear any of your comments or questions for the panelists. And if you do have a question, put your hand up. We do have some lovely people roving around with microphones. But let me just ask one last question on... Lotte, this is the $1 million question, right? As David said, how do you move from political will to implementation? Are the tools there for us to do it, for the world to move towards implementing those commitments made in the UN political declaration, for example, or any other commitments towards moving towards greater immunization?
Excellent question. You're asking a researcher, an economist. But yeah, no, I think it is really important to have, for example, like clear targets. Again, in vaccination, we see there are like clear targets what we want to achieve, and you can measure against whether those are achieved or not. In childhood vaccination, we've done pretty well. There are some changes, dynamics over time, as we're all very much aware. But again, when we look at adult vaccination, the numbers are very sort of variable. There's some vaccination programs do fine, and others have very low uptake. So we have to think about like implementation. Well, scientists are also sort of looking at experiments like what will work to make sure that people have the trust and the confidence and literacy to sort of get the healthcare, but also what can health systems do better.
I mean, some countries do it brilliantly. Australia apparently on track to eliminate cervical cancer within a decade. So it can be done.
Yes, and again, sort of having those very clear targets is really important. We've seen that with HIV, we've seen that with screening, with adult vaccination, with any vaccination. I think that is like step one. And then, of course, like looking at best practice examples, like what works and why does it work. I think that's also very important to understand. Also, to Belinda's point, the context of why things work in certain contexts, in certain regions, and so that we can learn from those examples.
Great. Panelists, thank you very much indeed. I'm going to turn it over to the audience. Right, loads of questions. Let's start with the gentleman who's already standing up very helpfully at the back. See, you snooze, you lose, everyone else. Just wait for a microphone. Thank you.
Hello, I'm Stefan Peterson, Karolinska Institutet, Sweden. We spend 97% of our healthcare budget on healthcare and 3% on prevention, and I've looked across Europe, it's the same. And I find typically when we have panels like this, we talk about health, but then we end up discussing healthcare. To some extent, I think we've done that today as well. Vaccination being, I think, arguably one of the few preventive things that healthcare does well, which is not to belittle healthcare. I'll take my treatment when I'm a patient. But while I'm a citizen, what is the promotion and prevention we could effectively do? And do you think that healthcare will be in a position to deliver that? Or do we need to set up separate prevention organizations, separate budgets, and Francesca, separate economical and measurement frameworks so that the food system, the city planning, and all of those things, that the real health determinants factor in here and not just healthcare?
Thank you for the question. I think that was directed to you, Francesca.
Well, look, separate framework in a way, yeah, it's important to have a framework for prevention, public health, what that delivers, and I mean, it's much of the work that people like us at OECD, but also what Lotte is doing, really try to see, okay, what are the returns on investments, what are the co-benefits of prevention and public health for other sectors, fundamental. The separate budget is a little bit more tricky because obviously there is an issue also of integration, and some countries that try to ring fence some of the budgets, you know, they might, it might work in the short term. Do they keep in the long term? And in general, Ministry of Finance hate earmarking. They think that the money should be much more fluid and able to be integrated. So it's a little bit more tricky. I mean, there is a fundamental issue that you're right, only 3% on prevention, public health. We need to address the 97%. I mean, I know this panel obviously is about prevention, public health, but we must address that 97% because a lot of it does not necessarily deliver good results. And I'm not saying that we don't need it. It's just that we must address that as well, not just trying to say, okay, let's increase, if you want, the budget for prevention public health, but also let's look at the 97%. I think that's something that we need to do.
If I can just add to that, indeed, when we look also, so starting within the healthcare system, when we look like what are we paying for out of our sort of healthcare budgets, we tend to underestimate the value of prevention because much of that falls outside of the healthcare system. And therefore, within the healthcare system, we tend to prioritize other interventions, leading this to, and I'm going to use a word that Francesca used just 2 days ago when we met, it's more of a sickness system, right? It's not about health, it's about dealing with sick people. And I think if we're going to sort of try and change that, that would also help to sort of, you know, inform decisions based on that evidence from a broader perspective and then make a decision about what is the right choice. There's the country where I'm from originally, the Netherlands, for example, takes a very broad societal perspective on doing those value assessments on all different healthcare interventions. And we do see that then preventive interventions tend to be, you know, have a less of a hard ride with those value assessments. I mean, it's always going to be tough. You will always need the data. It's never going to be easy. But it does help to sort of get that bigger picture a little bit more clear.
I couldn't agree more with the colleagues from Karolinska, but being practical, we are talking about 3 pillars of prevention. 2 are in the domain of the healthcare or the health sector, which are cancer screening and immunization in general and vaccination. The third, which is behaviors, lifestyles, is very difficult to change because, of course, it's outside of the health sector, is in the social and in the commercial determinants of health. I give you a practical example. We gave money for the member states to have a European Center for Prevention, which means to provide member states money and evidence to understand what are the best possible interventions to modify the behavior of people in order to adopt more healthy lifestyles. It wasn't passed because we need universal agreement by member states and essentially. So I would add to the ingredients that David said to the implementation of the plan, which is funding, transparency, accountability, leadership. We need strong leaders in order to do that. And sometimes it's very unpopular and difficult to do that because currently the commercial determinants of health are very strong in fighting, in particular in the food industry, which has powerful means to advertise for unhealthy behaviors, you know, particularly in children and in the healthy literate people. So it's going to be difficult. But if we already build the two pillars of cancer screening and immunization, I mean, would have been a great deal to grant sustainability to our systems.
Thank you. Another question from the audience, a gentleman at the front here. And then I'll come to the lady who was standing up. I just saw you, and I'll come to you next.
Great
Go
panel.
ahead.
Yeah, can you hear me? Yeah, great panel. Thank you for the insights. My name is Tural. I am Health Financing Advisor in GIZ. I have two questions. One is about hypertension. It affects 1.4 billion people, and only 20% of them are controlled, mostly in developed countries, with high-income countries. And if we can increase it to 50%, we can save 76 million people until 2050. It's almost population of Germany. Question to Francesca, what do you do in OECD, particularly to address hypertension? And the second question is about political advocacy and how we can push governments and Ministry of Finances to spend more on prevention. As you said, Walter, even with the allocated money, they don't spend on prevention because building hospitals is more attractive, it's more visible, but the hospitals will not solve the hypertension crisis or NCD. So the question is that Global Fund, since 2022, saved 70 million people by addressing vertically AIDS, TB, and malaria. And it was effective because it had funds, and it has power, it had influence, and it had everything to be successful. Do we need another vertical global fund on prevention, particularly on NCDs, to save another 70 million people in the next 10 years?
So
thank you.
We're not talking specifically about NCDs, but I get your point about prevention and controlling specific high-impact conditions like hypertension, and this is obviously one of the goals of the political declaration. Francesca, is there more granular data which looks into specific areas of prevention which might have an impact?
Yes, we do have granular data in prevention spending and so forth. We are doing actually some work now in digging through the data as well and seeing if countries can improve it. Hypertension we look at as part of the broad risk factors. We have some work which is ongoing, coming up, is going to be released end of the year on cardiovascular disease more broadly. So it looks at the whole issues, obviously, of preventions of risk factors. Clearly, there are issues about what has been said about the role of people and individuals, about that making sure that individuals know that they need to go and get their pressure taken. That is not happening. There are so many persons that don't know that they have hypertension. That's to start with, and then there is obviously the access also to the treatment that you can use and adherence to those. So those are some of the issues that we look at. But
yeah, it comes back to health literacy, but I think there's also a context. When you talk about public advocacy, there are also cultural differences in countries. For example, when the HPV was first introduced, there was a lot of resistance from certain countries who thought it was a doorway to allowing more sexual activity amongst women, amongst females. So we have to be, when we talk about the need for public advocacy, I think we have to be sensitive about, is there enough knowledge about the vaccine in question or the medicine in question? And Francesca makes the point, most people don't know they've got high blood pressure until they're on stage like this, and then they realise that their blood pressure is indeed quite high. But so public literacy, maybe health literacy can only help you so far? I don't know. What do you think, Belinda?
Well, yes, to public literacy, because what that does is it empowers people to know what's good for them, to ask for the right, interventions, sort of to demand it. So I'm a firm believer in public literacy.
The power of the people,
yes. Power of the people. In addition to that, and that's not to take the conversation back to the healthcare space, but it's about sphere of control and where I find myself primarily. If you look at, for instance, rolling out some of these prevention packages, ability to reach people also will depend on how we bring in the private sector. Typically, if you want people to come check your blood pressure, we have these wellness clinics in Ghana where you can walk in, even though you are healthy, to check your blood sugar, check your blood pressure. But it's in the public sector. And yet, we have a very mixed health systems, especially in the urban areas. So you would find that our ability to, this wouldn't be the last mile, but sort of to reach more people is also dependent on how we're able to take the prevention agenda and bring in our partners in the private sector to also, to sort of be a platform through which we'll roll out these preventive interventions, and that's, to me, if we are able to do that very well, would also be helpful.
Okay. Anyone else want to add to that? No? Okay. So there's a lady at the back who is standing up. We'll go to her next. Thank you.
Thank you very much. Good afternoon. My name is Lucille Herman. I work for Global Health Advocates, or GHA. We are an advocacy organization based in Paris and Brussels. And I'd like to come back to the points that were made on how to build coalitions and how research is also fueling this debate. My question would be how to better associate research to those coalitions to have prevention presented as a way forward. Our contribution as GHA, we will relaunch a report tomorrow called No Eradication Without Innovation. It prevents prevention tools that has been developed over the 20 years, last years, thanks to innovation, thanks to research. Lenacapavir against HIV, digital health against tuberculosis, mosquito nets against malaria. But it also demonstrates the very terrible impact of the fact that science is more and more under attack. So yeah, my point and my question being how to better associate research to that coalition. Thank you.
Thank you. Well, maybe, David, I can bring you in here about better partnerships, better coalitions to progress research and development, and what do you need to make them true, effective partnerships?
So I think the answer to this is at a number of levels. And I think the first thing is at the level of strategy to, I think, involve multi-stakeholder groups in the development of strategy. And this also includes the private sector. It's really interesting that often in the global health area, we talk about inclusion and diversity, and yet people are very comfortable to exclude the private sector. We do have a diverse view, but that can actually be a strength, and there's a lot of expertise that can be brought to the table. There are also very productive examples of how we can work together, and I think the product development partnerships are a great example of that, where industry partners with entities that have a not-for-profit basis bring expertise to the table, and you can then work together with co-funding to bring forward new interventions. And we've seen this in malaria with MMV, we've seen it with DNDi in neglected tropical diseases. We spoke about the vaginal microbicidal ring earlier. That's another product of this. So a lot of good things have come out of it. At another level, just in terms of healthy partnerships, and just looking at the landscape, partnerships have changed. And I think they used to be extractive. And I'll give you an example of what an extractive partnership is. I once spoke to an investigator that was working on a study from an African country, and I asked him how the study was going, etc. And he said it's really good, and we were involved in funding it. And I asked him what input he actually gave into the protocol, etc. And he said, well, not much. But that's not an equitable partnership. Actually, it's extractive because you're going in, you're telling somebody what to do, you're taking what you want out of it. Now, then you can come to a consultative where you actually consult people and get their input into it. Eventually, you can become co-creative and co-leadership. So there's a spectrum. You don't want to be down that end of extractive. Nobody will tolerate that now. And I think that cuts both ways in terms of the way people treat industry. It can't be extractive. And in the way we all treat one another, it can't be extractive. So it does need to be a true partnership. And I found that just working in the HIV area, I saw one of the most amazing transformations take place. And that was from being an industry and being literally attacked by HIV activists to the point where I needed a bodyguard at one point in my life, to a point where we're sitting down with HIV activists, developing clinical trial protocols and getting their input in because they know what it's like to be a patient, and I didn't in that context. And so they had something really valuable to offer to make sure that that clinical trial served the needs of patients. So I think we just need to reframe things as true partnerships and perhaps not tell people what they should do, but ask them what they can do and what their ideas are.
Yeah, it's a very good point about including the patient voice. Does anyone else want to add?
Yes, very briefly. I think, researchers and everyone else, we're really, really good at sort of talking amongst each other and aggressively agreeing about all the wonderful things we do. And of course, that is not going to sort of help us all forward in a coalition. So I think that is critically important. And I think also on a point that the person who asked the question made, I think research should never be political. We do know that research can have political implications, and as Belinda said, health can be political, often is. But I think we have to be really mindful that research should be about the research and be really good at telling that story, but stick to the evidence and the facts as we have it, and also be open to, be challenged on that research, because trust is key. As soon as researchers turn into like pure advocates, I think that is also something we have to be mindful about in terms of building bridges and building ways forward together.
Thank you. Let's see if we can get through a couple more. Lady in the second row at the front here, in the blue shirt, if you stand up.
Thank you so much for the insightful discussion. My name is Dominika Flisek. I am a Polish medical student representing here the International Federation of Medical Students Associations, IFMSA, which represents a total of 1.5 million medical students worldwide. And as an organization, we develop campaigns and surveys on NCD prevention. We conduct advocacy action. We reach out to key stakeholders, including our national governments. So my question is that knowing that currently the biggest gaps in prevention are the mindset change and the proper funding, increasing financing by the governments, do you see any potential in medical curriculum development to increase our meaningful contributions to the topic? Because additionally, as medical students, we are somewhere between being medical professionals and a person from the civil society. So how do you see our role in this activism? Thank you.
That's a great question. Thank you very much. Belinda, why don't you take that?
Yes, before I answer the question, just to let you know, 21 years ago, I was a medical student. My very first international trip was actually to Germany, and I was hosted by another medical student here in Dresden, and she brought us two of us from Ghana to Berlin to visit her family. 21 years later, I'm here. So your role actually is not even just limited to now as part of IFMSA. Medical students across the world have a powerful voice. We're trusted. When you go out into the communities and you're dealing with patients or communities, that is a platform to self-prevention. But more importantly, in a couple of years, you're going to find yourself in leadership roles, whether as clinicians, as policymakers, or in research. And just take this conversation, this platform, as part of your training. So it's not just about what you're going to, your role just in present days, but just even what the future holds. And good luck.
So no pressure, but in 21 years, you'll be on this panel. And because we're all working later, in 21 years, I'll still be moderating it. So. All right, one last question. Gentleman in the maroon shirt. Yes, please. Thank you.
Hi. Thank you so much for the session. It was really good. I'm posing a question which is mostly directed at Lotte, but also Francesca, I would say. So just as you started the session, you stood up and you showed a very good metric, which is good to convey a certain idea of how money and health works, which was the 19 return on investment. Later on this session, you have tried to convey another idea, which is the impact that, for example, distributing vaccines at community pharmacies has on the distribution on health equity. right? My question is, in health economics, we do have some metrics also to quantify these. We can do distributional analysis, we can use CAC1 indexes, we can use concentration curves. Now, I think that if we had such a similarly good metric to convey this idea of distribution of health equity, I think we would be much better at communicating. Do you think that there is a way for this?
I would fully agree with you. I think that is really, really important, indeed. And I know like the methods exist to sort of do that. And again, this is one example where we as health economists are very good at sort of developing those methods and doing studies, but maybe not so good at coming up. And sometimes I found it as well with this study. The number of details behind what's now called the 19 report are just, very, very almost endless. There's a very long report, but at the end of the day, we have to find one metric that resonates with people, that opens the door, and then you can have all the nuanced, discussions following from that. But without that, you don't even get a seat at the table. So I think that is really what we would have to do, using all the knowledge we have within the research field. Good point.
Francesca, do you want to add to that?
Yeah, I mean, you need to have some headline metrics that get the headings. I mean, for us, it's this 3%, which is the spending on prevention relative to total health spending. It has remained constant. It went up during COVID because of the vaccine spending. Now it's going back to the level. At the same time, you need to convince different people, and you may want to have metrics that speak to those people. I mean, I did mention if you're talking and want to have a cross-sectorial approach, which is what we need when we're talking about prevention public health, well, the people that you have in front of you may reason with different metrics. And I think you need to acknowledge and recognize that. So in a way, yes, a headline that, hits, perhaps also that speaks to leaders and so forth. But then also, conversations do require more specific metrics, whether they're about labor markets, whether they're about education outcomes, whether, you name it.
Does anyone else want to add to what metrics resonate with policymakers? What's going to move that needle? I guess if we knew the answer to that, we wouldn't be here, would we? Listen, I'm going to have to draw it to a close because we are running out of time. I really appreciate all the questions. Thank you very much indeed for that. I want to just throw it back to the panel for one last thought, one last call to action, one last opinion. What needs to happen as a priority to move towards prevention-driven healthcare systems? Let me start with you, Lotte.
Yes, first of all, I think we should embed adult vaccination in the national programs and also collect sort of more granular data on that so that we can sort of see what's happening over time and track that. And I know OECD is doing that. So that is super important, and really recognize that prevention is a strategy. Basically, every dose of vaccination or dose of prevention, if you like, is a dose of health, a dose of productivity, a dose of sustainability. And that is increasingly important given the current situations we're in this world globally.
Walter.
I would like to close with a rather general comments, but an optimistic one, which means that these are difficult times, but I'm confident that even in this audience, and I'm starting from the consideration by the medical students, there are the possible young leaders that are going to lead outside of these difficult times. Of course, it's not going to be easy, but we need you in order to think in a different way and to propose some solutions that maybe we don't envisage yet.
Thank you very much. Francesca?
I would say, in a way, the people-centeredness. I mean, we need to really make sure that we think and always bear in mind that what we're talking about is having health system prevention and so forth that deliver to people. And I think it goes back to what you were saying at the very much beginning. We need to get that also force that comes from individuals per se that can mobilize change as we move forward. So, I mean, of course, as for my organization, I can talk about data, incentives, that's our bread and butter, but I think that people-centeredness is fundamental.
Thank you. Belinda?
I would say in this very fragmented times, one of the pathways, perhaps the key one to even, going ahead with prevention is our ability to make friends, to build networks, to have conversations. It will take us further and to build these coalitions, whether across sectors, with the private sector, for policy and research to come together. Just that power to come together, to believe in this, would take us really far in making it happen. So let's just go back and not be as not just to, for us to keep on being fragmented or for it to worsen, but just to make an effort, be very deliberate to come together for one cause.
Thank you, Belinda. And David.
So I think just a recognition that prevention and early intervention is actually cost-saving, and moving governments towards action. And we've heard about the data today, and I think one of the things that moves governments towards action is the voices of the people and what their people that they serve want. I think we need to get far better at communicating the case for prevention, the case for vaccination. And I think just one last, can I ask for audience participation? Put up your hands if you're a scientist or a physician. Yeah, there's a lot here, but it's good to see that it's not all scientists and physicians. Because we tend, part of the problem is us. And so I can tell you how to develop an antiviral or a malaria drug, but I'm not very good at telling people and talking to people actually in a way that's convincing if they don't believe me. And we need to get a lot better about this. And I think the conversation that you mentioned is absolutely critical. And we can't start from a point of arrogance. And the point of arrogance is, I'm a scientist, I've seen the data, I know this is right and you're wrong. Because the truth is that no parent that makes a decision about their child's vaccination does so intending to harm their child. So what is their motivator? And how can we have a very reasoned discussion around this and begin to move people towards greater trust in vaccination and in early screening and prevention, so that it becomes something really important to them and really important to their governments?
Thank you for all your insights, the right metrics, public advocacy, effective coalitions, rethinking of fiscal policies, and scientists learn how to speak to politicians. Thank you very much. Please give our speakers a round of applause. Thank you.